Welcome to the North Carolina State Medical Response System Initial Training Program for the State Medical Assistance Team. This presentation covers Module 3, Infection Control. This module has 6 objectives. The first 3 are: discuss basic infection control definitions and concepts relevant to SMAT operations, discuss infection control in clinical settings, describe infection control issues relevant to field operations. The last 3 objectives are: discuss pre-deployment, deployment, and post-deployment infection control, describe SMAT-specific infection control roles and responsibilities, and finally, describe SMAT infection control measures that integrate with public health. Remember, safety is important in everything that we do. Diseases spread in very specific ways. When we understand the routes of transmission of infectious diseases, we can prevent their spread during deployment. By following infection control protocols, you can expect to stay free of disease. For those of you that are medical providers, this should be a good review. For those of you that are non-medical, this will be good baseline information for helping you understand the importance of infection control. Let's start with an introduction to communicable diseases and talk about some of their basic concepts. In the United States, transmission of infectious diseases to patients and staff in clinical settings is mostly caused by microbial or biological agents such as bacteria and viruses, and to a lesser extent by fungi, protozoa, parasites, and other rare infectious proteins. Bacteria are one-celled organisms found in almost any environment. Most have the ability to multiply on their own if given proper nutrients and environmental conditions. Viruses are infectious particles composed of genetic material that enter a cell and replicate by taking over critical activities of that cell. Bacteria and viruses cause many of the common human infectious diseases in childhood, healthcare facilities, shelter settings, and following traumatic injuries. Humans become ill from infectious disease when they come in contact with others who are infected. This may occur through direct contact, exposure to respiratory droplets and aerosols, or contact with body fluids. On occasion, microbes will persist in the environment, food, water, or within the soil and may cause disease in humans when humans come in contact with these materials. Certain infectious diseases, such as rabies, can be spread from animal to humans, and some infectious diseases, such as the West Nile virus infection and malaria, are spread by mosquitoes to humans. Infection control practices are designed to interrupt the various ways that infectious diseases are spread to and among humans. While disease outbreaks have appeared on occasion after natural disasters, new diseases generally do not emerge that were not already present within the population. Although North Carolina has periodically experienced natural disasters like wildfires, winter storms, tornadoes, and hurricanes, disease outbreaks have rarely followed. By contrast, there was a cholera outbreak following the Haitian earthquake of 2010 when the lack of sanitation and clean water promoted the explosive spread of cholera. This outbreak is thought by many to have been brought to Haiti by external emergency responders from other geographic areas where cholera is thought to exist. In addition, there were frequent methicillin-resistant Staphylococcus aureus, or MRSA, infections that occurred during the Hurricane Katrina relief effort. Also, contaminated food or water may cause disease in emergency responders. To prevent and control infectious diseases, clinicians and public health workers look at 3 areas. First, infection control measures that target the biological agent, like heat or chemicals or radiation. Second, interventions that assist the host in treating or preventing infection, like antibiotics. And third, direct a change in the environment that reduces the potential for acquiring an infection, like bandaging or implementing mosquito control. Interrupting the spread of the biological agent usually requires the targeting of at least one of these three interventions. They are often referred to as the communicable disease triangle, which is comprised of the agent, or bacteria and viruses, the host, or humans, and the environment, or source of the infection. One of the most common and effective interventions to interrupt the transmission of disease in field settings is simple hand washing with germicidals. This reduces contact with biological agents and lessens the likelihood someone will spread disease to others. Friction created with the act of washing lifts biological agents from the surface of the hands. These agents are then washed off with the soap and water. In fact, several studies have shown hand hygiene is considered the most important measure for preventing healthcare-associated infections and the spread of antimicrobial resistant pathogens. Take a moment to review the factors related to disease transmission and some examples of control measures. Despite differences among the type of infectious agents and the risks they pose to humans, a general set of infection control measures is employed in patient care settings to reduce the potential for spread of any disease. These measures are based on interrupting the methods by which biological agents are spread and are called standard precautions. These measures focus on protecting the healthcare provider and ancillary staff from being exposed to infectious diseases. They also reduce the likelihood that patients or healthcare providers will transmit infectious diseases to other patients in healthcare settings. Standard precautions are followed to prevent the transmission of infectious diseases in healthcare settings and are used when caring for all patients. Standard precautions were adopted in 1996, combining principles from body substance isolation protocols and universal precautions to create a standard system to reduce disease transmission in healthcare settings involving patients and healthcare workers. Standard precautions assume that every person is potentially infectious and or susceptible to infection. State medical assistance team members should use these precautions when dealing with any patient and wash their hands frequently to reduce the spread of a disease among healthcare workers. As a side note, most healthcare workers usually follow the rule of, if it's wet and sticky and not yours, don't touch it. Standard precautions rely on a physical, mechanical, or chemical barrier between infectious microorganisms and a susceptible individual. The use of standard precautions is an effective strategy for preventing the spread of infections. Underlying this protocol is the need to consider every person, whether patient or SMAT personnel, as potentially infectious and susceptible to infection. The major components of standard precautions include hand hygiene, use of personal protective equipment or PPE depending on the anticipated route of exposure, safe injection practices, and proper environmental cleaning. Infection control refers to various measures that are employed in clinical settings to limit the spread of infectious disease. In many situations, infection control attempts to limit the spread of disease from infected patients, the environment, and in some cases, from infected staff. Proper procedures for individuals and organizations are required to reduce the risk of spreading infectious diseases in clinical settings. Infection control measures include the proper cleaning of equipment, proper disposal of medical waste and used needles, the use of proper barriers to prevent health providers from becoming infected, and hand hygiene. In the absence of good infection control practices, health providers and patients may become ill with infectious diseases that could threaten continued SMAT operations. An awareness level of knowledge related to SMAT infection control requires familiarization with a few additional key terms that will be used during deployment. These are listed on the slide, and I will define them for you. Patient screening. Procedures used in clinical settings to assess patients for their potential to spread a communicable disease before entry into the general population of a healthcare facility are referred to as patient screening. Patient screening areas were employed at the entrances into clinical facilities and were used extensively during the outbreak of the Severe Acute Respiratory Syndrome, or SARS, in 2002 and 2003. Isolation. Patients who are ill from a contagious disease are isolated from other persons who are susceptible. The purpose of isolation is to prevent infected and ill persons from spreading their disease to others. It is one of the primary strategies for infection control. Quarantine. Quarantine, in its most basic public health form, seeks to remove people who may be harboring a disease, but who are not yet ill, from contact with other persons. The purpose of quarantine is to prevent potentially ill persons from spreading disease to others. Generally, persons are placed in quarantine for a period of time exceeding the incubation period of a disease, or until they are deemed to not have the disease or not be contagious. Remember, quarantine is for persons who were exposed but who are not ill. Isolation is for patients who are currently ill. Immunization. Immunization is the act of providing a person with an exposure to a virus or bacteria so the person can develop protective antibodies against the disease. With regard to an infectious disease, this commonly involves receiving an injection with key components of the infectious disease agent of concern. The purpose of this preventative health strategy is to make the person immune to the disease by helping the body develop protective antibodies against the biological agent. Infection control and ESMAT operations falls into two general measures to reduce the spread of disease. First, they target strategies to prevent the spread of infectious disease from one person to another. And second, they reduce environmental exposures that might lead to infectious diseases. From a team perspective, separating ill team members from others working in the field is extremely important. In camp settings, ill team members should be removed from their duties and isolated from health workers. This may include confining ill teammates to special housing or providing access to designated areas for additional opportunities for personal hygiene. For example, during the recent Haiti earthquake response, medical teams developed separate toilet facilities for healthcare workers who suffered from diarrhea as a way to help reduce the transmission of disease. It is important to understand that the mainstay of an effective ESMAT infection control program will be the enforcement of individual and organizational measures to reduce the spread of infectious diseases to workers and patients. Remember, while it may feel inappropriate to stop work because you are ill, it is in the best interest of the people around you if you take steps to minimize the spread of your illness to others. The Association of Professionals in Infection Control and Epidemiology also developed a broad set of medical waste guidelines for healthcare workers responding to disasters. Many key awareness concepts for ESMAT members for the safe handling of medical waste are listed on the slide. These include body parts, blood, or body fluid and waste should be placed in bags labeled regulated medical waste or placed in biohazard bags pending removal. Regulated medical waste should be stored in an enclosed and secure location while arrangements for proper disposal are made. These are areas of concern to prevent the spread of bloodborne pathogens such as HIV, hepatitis B, and hepatitis C. Also, any exposure to blood or bodily fluids by ESMAT personnel requires immediate reporting to the ESMAT team leader or infection control officer. Let's talk a little bit more about standard precautions. ESMAT personnel must assume that every patient possesses an infectious disease risk to self and others in the clinical setting. Therefore, standard precautions are used to control the infectious disease risk to ESMAT personnel during deployment. Hand hygiene. The single most important measure for preventing the spread of pathogens is effective hand hygiene, which is defined as any method that removes or destroys microbes on the hands. Hand washing with soap and water is the preferred method to remove potentially infectious material from the hands. In field conditions, hand washing stations may not be available or operational. In that case, the use of alcohol-based sanitizers of 60% to 95% ethanol or isopropanol in the form of gels, foams, or liquids can be used if the hands are not visibly soiled with contaminated organic material. The physical layout of the SMAT deployment should ensure the easy accessibility of hand hygiene products such as soap, clean water, or alcohol-based hand rubs, ideally at the point of care and immediately after. Personal protective equipment. The use of physical barriers to protect SMAT personnel from splashes and spills is an important part of standard precautions. These barriers can include protective goggles or face shields, gowns, respirators, or gloves. SMAT personnel should choose PPE based on an assessment of the procedure to be performed and the mode of transmission of the potential agents. Gloves. Whenever SMAT personnel expect to touch an individual's blood or body fluids, non-intact skin, mucous membranes, or contaminated items, gloves should be worn. Sterile gloves are not required. Change gloves when they become heavily contaminated or to prevent cross-contamination with other body parts or sites. Avoid touching surfaces in the SMAT environment or yourself with contaminated gloves. Change gloves after providing care to each patient. If you know you're going to be in a situation where you're going to be caring for multiple patients at a time, it's sometimes better to start with wearing multiple layers of gloves rather than trying to put on a different pair after each patient, because then you can simply take off the top layer and move to the next patient. Goggles, masks, and face masks. These protect the mucous membranes of the eyes, nose, and mouth when contact with blood or body fluids is likely. Gowns. When splashing or spraying with blood or body fluids is possible, based on the procedures planned, an isolation or procedure gown should be used. This helps protect the SMAT personnel's skin from blood or body fluid contact and prevents soiling of clothing during procedures that involve blood or body fluids. Safe needle use. Investigations into several outbreaks of blood-borne pathogens like hepatitis B and C have indicated several breaches of infection control practice, including reinsertion of used needles into a multiple-dose vial or solution container, and use of a single needle or syringe to administer intravenous medications to multiple patients. Recommendations to prevent this kind of breach include the use of a sterile, single-use disposable needle and syringe for each injection given and prevention of contamination of injection equipment and medication. SMAT personnel should be instructed in these methods to prevent the spread of blood-borne pathogens. Needles and other sharp instruments, like scalpels, pose significant risk of injury and possible transmission of infectious agents to susceptible SMAT personnel. Properly handling, cleaning, and discarding these sharps will greatly reduce the risk of sharps injuries. Used needles should not be recapped, broken, bent, or manipulated by hand. Needles and attached disposable syringes should be discarded as one unit in approved puncture-resistant containers. Reusable sharp instruments should be handled with extra care when cleaning and preparing for reuse. Proper environmental cleaning. Appropriate and safe cleaning of linen, patient care instruments, and environmental surfaces provides protection against disease transmission. Extraordinary measures are generally not required to sufficiently clean linen, equipment, and patient care area furnishings. When cleaning soiled linens, handle them in a way as to avoid letting the linen touch skin. Gloves should be worn when handling such linens. Soiled linens should not be pre-rinsed in patient care areas, but should be transported with as little handling as possible to the laundry area. Patient care equipment should be cleaned in a way to prevent contact with skin or mucous membranes and to prevent environmental contamination. Reusable equipment should be cleaned prior to reuse. If reuse requires sterile conditions, the equipment should be sterilized before reuse. Environmental surfaces require only routine care and cleaning with available disinfectants. Immunizations. All SMAT personnel should have completed all necessary immunizations prior to deployment. Requirements for immunizations are listed in the MOU, or Memorandum of Understanding, between the North Carolina Office of EMS and participating hospitals involved in the SMRS and SMAT activities. These immunizations include tetanus vaccine within the last 10 years, hepatitis B vaccine or a positive titer within the last year, tuberculosis skin test within the last year, and a chest x-ray if the tuberculosis skin test has a positive result. This applies to all team members for a deployment. However, if there are special circumstances in the deployed setting or additional risks, additional immunizations may be recommended or provided. Respiratory hygiene, also known as cough etiquette. This simple activity may reduce the spread of airborne or respiratory droplets in the SMAT clinical setting. Upon sneezing or coughing, an individual should cover their nose and mouth with a tissue, mask, or the sleeve at the crux of their elbow. Used tissues and masks should be disposed of properly. Hand hygiene should be performed after contact with respiratory secretions. Patients, clients, and others in the SMAT environment should also practice this, and instructional posters should be posted in all areas. Tissues and disposal receptacles should be placed throughout the area. Infectious disease risks that are present in routine clinical care settings are also present in field situations. The special circumstances associated with each SMAT deployment may contribute additional risks related to infection control. SMAT operations related to communicable disease emergencies, such as pandemic influenza or cholera, may pose additional infection control challenges to SMAT deployments. The primary SMAT infectious control objective during these situations is to prevent the transmission of disease to SMAT members and from SMAT members to the community. Intensification and enforcement of infection control measures should be both an administrative and an infection control priority during these deployments. In certain situations, SMAT members may require prophylactic medications. Prophylaxis is the use of antibiotics, antiviral agents, or antitoxins to prevent an exposed individual from becoming ill or to mitigate the severity of that infection. For example, during the H1N1 pandemic, individuals who were exposed to that virus were given a course of Tamiflu to prevent them from becoming sick. Medical prophylaxis is designed to stave off symptoms by making the host, your body, unattractive to the infectious agent, not provide immunity to the disease. If you stop taking the prophylactic medication while still at risk of infection, you may become ill. During a deployment, there should be an organized time when team members can be medically assessed and receive medical services. What may appear to be an insignificant illness or injury should be reported to SMAT leadership. This is particularly important if illness or injury requires health providers to be taken out of their clinical deployment duties. In summary, infection control in SMAT operations involves a basic knowledge of communicable diseases and measures designed to interrupt the transmission of infection from one human to another, or from the environment to humans. This is also critical to protecting the health of SMAT personnel. Standard precautions are used in clinical settings by healthcare providers to limit the spread of infectious diseases. Training and enforcement of infectious disease practices in clinical settings are key to the successful mitigation of the risk from infectious diseases to SMAT personnel during deployments. SMAT infection control begins before deployment with proper immunizations of staff, training in infection control practices, and other measures to reduce the possibility that personnel may become ill during a deployment. In addition to the operational and administrative integration, SMAT medical surge response should be integrated with the public health emergency response through measures to identify patients with communicable diseases before they are released into the community. SMAT participation in disease surveillance can be critical to identifying, treating, and preventing an epidemic.